Good morning, everyone. Very good evening, sir. I am privileged to introduce Professor Dr. K. Ranganathan. He is presently the professor and head of the Department of Oral and Maxillofacial Pathology, Raga Dental College, Chennai. He is the first Indian oral pathologist to hold many notable leadership positions, namely President, Asian Society of Oral and Maxillofacial Pathology, and Secretary, International Association of Oral Pathologists. He is also the chairperson, Fellowship Committee of Indian Association of Oral and Maxillofacial Pathology. As an academician and a global researcher, he has more than 200 published papers and has 9 textbook contributions to his credit. He also has won numerous awards, notable ones namely Bennett Graduate Research Award by Ohio State University, USA, and Perpetuating Academic Excellence Award by Tamil Nadu Dr. MGR Medical University. He is an excellent orator, having delivered numerous guest lectures. And the podium is for you, sir. Now, we welcome you. You can go ahead, sir.
A very good morning to you all. First, let me thank the chairpersons, the organizers, and personally Dr. Mahalakshmi for having extended this invitation to be here with all of you in Spirit 2023. It's a pleasure to be here and share some time with you all. And thank you for the kind introduction. Puts a lot of pressure on me, but let me see I can justify that. Okay, when I spoke to Dr. Mahalakshmi many months back, actually, and I asked her, what exactly do you want me to talk in this? This seems like an endodontic meeting. And she said, the current concept is how to conserve pulp. Sometimes we call it the dentin pulp complex. In fact, looking at your program here, you already had 2 fantastic lectures on the first day on conserving dentin and on conserving strategies for conserving the dentin pulp complex. And what I thought I would do is I'd approach it from the biological point of view, being a pathologist and also wearing the cap of being a clinician. What exactly do we need to know about the dentin pulp complex for the purpose of preserving pulp and saving pulp? And I think this is the crux of the boundary in which we are today between conventional endodontics, which involves root canal treatment, pulpectomy, and sort of procedures which are not very conservative, to what we are now calling as regenerative endodontics or minimally invasive vital pulp therapy or pulp treatment. What I intend to do today is in the following order. Let me talk about the components of dentin and pulp complex and what happens when there is a damage to this complex and its response, and what are the current concepts in repair or regeneration of this complex, and what exactly the clinical translation is. Now, to conserve pulp following damage to the pulp, or in other words, pulpitis, you need to have an understanding of the homeostasis involved in maintaining pulp health, the pathophysiological response once there is any harm. You need to understand the pathophysiology so that you could harness the restorative or the regenerative capacity of the dentin pulp complex. I sort of use the word pulp for dentin pulp complex because that's a huge word. So when I say pulp, I obviously imply the dentin pulp complex. So we need to understand how we can harness its capacity to repair itself and to regenerate itself so that you can have an understanding of how all the components, the dentin, the odontoblast, the different cells of the pulp, the extracellular connective tissue matrix, how they interact with one another both anatomically, how they communicate with one another during trauma or a physiological response or a pathological response, so that you can manage the health of the pulp optimally. And this is not only necessary for the management of the pulp in a clinical context, but this is also going to be useful to evolve diagnostic tools which can help you to actually assess the damage to the pulp and how you can manipulate your diagnostic results or how you can use the diagnostic results to manipulate your clinical treatment protocol. So let me start with the first component, the biology of the dentin-pulp complex. And I will use the word pulp for the dentin-pulp complex or the pulp-dentin complex. People use it interchangeably. Okay. It's very important to understand that I'm sure this has been talked often, that the pulp is an ectomesenchyme. And the ectomesenchyme of the head and neck, the connective tissue of the head and neck, is very unique because it is of a neural crest origin. And the neural crest, without making it very complicated, is what are a group of cells which originate during the development of the central nervous system. Now, if at all you need to know anything, there's one very important fact you need to understand about why we talk about ectomesenchyme. Because it derives from the neural crest. It has the ability to migrate. And I'm sure you're all aware that the neural crest cells give rise to Schwann cells, melanocytes, your dental pulp, the connective tissue in the head and neck region. These cells have fantastic capacity to migrate and differentiate into a wide variety of cells. So what this means for conservative dentists or endodontists or restorative dentists is that the reserve cells in the pulp or the stem cells in the pulp have got amazing capacity to migrate and differentiate into a wide repertoire of cells. And the pulp is, of course, made up of not only cells, but also connective tissue. Okay, when we say cells and connective tissue, the cells and connective tissue include your odontoblasts, the different zones which are rich in cells, and then the cell-free zone made up of plexus of vessels and plexus of nerves. And it's also important to remember that we're not dealing with a very large tissue. When you're looking at the size of a pulping approximately around 0.02 cc's on an average. Of course, it's going to vary between the anterior and the posterior teeth. And if you totally take all the permanent teeth out, it's got a capacity of only about 0.38 cc. It may be very small in volume, but it's got a very fantastic regenerative capacity and a niche of stem cells. And I'll talk about that in a few minutes. But that is also a problem because it is very, very small. Any inflammation is going to quickly damage the pulp. And I'm sure you're all aware that I don't have to emphasize that one of the cardinal signs of inflammation is edema or swelling. And since the pulp is very small, in a confined space, the damage to pulp can be very, very rapid if you don't interfere with any pathology which is going on with the pulp. Let me talk very, very briefly about the cells because you need to understand how these are eventually going to interact with one another in managing different pathosis. Of course, the prime cells are the odontoblasts, which are involved in the formation of dentin. And then you have fibroblasts and fibrocytes. And some books or some journals talk about what is called the cells of Weyl, cells of Hall. These are cells which have properties which overlap between those of fibroblasts and odontoblasts, and they lie just below the cell-free zone. And they are supposed to play a very important role in the formation of reparative dentin. And of course, stem cells, which are the exciting thing about pulp. Not only are they useful in helping the pulp to heal in response to local trauma or local infection, but they can be a potential source of stem cells for management of other health issues in other parts of the body. And you have numerous researchers working on these. And stem cells are of different types. These belong to the mesenchymal type of stem cells. I'll talk a little bit about them in detail as I go along. And these cells are present in what is called the perivascular niche. This is a particular area. If you look at the body as a whole, and when you talk about what we call as the adult stem cells or stem cells in an adult, as opposed to an embryological stem cell, they are present in specific compartments in different tissues. So these compartments are called niche, and in the case of pulp, they have a very perivascular location. And of course, you have different cells along with all the other cells, though these constitute less than 1% of all the cells. The major different cell in the pulp are the neutrophils. This is followed by T lymphocytes, macrophages, and dendritic cells, and a small percentage of natural killer cells, B cells, and regulatory T cells. When you come to the connective tissue, or what we call as the extracellular matrix, you have collagen fibers, predominantly the type 1 and 3, some amount of elastic fibers, the ground substance made up of glycosaminoglycans, water, and glycoprotein. And then you have the blood vessels and nerves. The blood vessels, of course, are lined by endothelial cells, and nerve fibers, you have both the myelinated and non-myelinated fibers. So these are the anatomic components of the pulp, and along with the odontoblast, the so-called pulp dentin or the dentin pulp complex. And all these interact with one another, talk with one another. These are not just passive elements, each having its own function. Each of their function is dependent upon the sort of communication which they have with the other cells and the extracellular matrix to make the dentin pulp complex almost like a vital organ on its own. So with a brief idea of what the components are in the pulp, let's see how these components actually contribute to respond to any damage to the pulp. Of course, I don't have to talk much about this. I'm sure you're all experts in this field as to how exactly there can be an insult to the pulp. It can be bacterial, of which dental caries is the most important cause. It can be physical causes such as trauma, post-radiation. You can have chemical causes, which can either cause erosion or dissolution of the hard tissue and subsequent insult to the pulp. And of course, we talk about this a lot, the dental procedures themselves, be it the process of making a cavity preparation or preparing a cavity preparation for a restoration can cause damage to the pulp. And of course, the restorative material, things like acid etching without any sufficient protection, or other restorative materials which have got either an acidic pH or chemicals which can permeate into the thin dentin via the dentinal tubules, can significantly affect the dentin pulp complex. So whatever be the damage, the pulp response, and this response to the damage is what we call immunity. It can be either what we call as an innate immunity or an acquired immunity. The mechanism of either of these is slightly different. And I'll talk about that in a minute. And what does this immunity actually do? This immunity is responsible for the inflammation so that the harmful substance, be it bacteria or a physical factor, is limited and the pulp can repair itself or can regenerate itself. So it's important to understand that the purpose of this immunity is to help the pulp overcome the trauma, overcome the damage, overcome the insult to itself, and repair itself or regenerate itself. It's very easy to fall into the trap of thinking that any of the factors on the left side eventually cause either total or partial destruction of pulp, and they don't have any beneficial effects. No. Inflammation, if actually handled well and controlled well, can actually help the pulp to heal and can help, in a case of an immature tooth, for the root to sort of, regenerate and attain its normal growth, lined by dentin and healthy pulpal architecture and function. Now, this is a concept we talked in the clinical context. We talk about reversible pulpitis and irreversible pulpitis. And I think the current dogma is that severe pulpitis is irreversible. Uh, in the light of all the molecular work which is going on and an expansion of our knowledge of how the pulp responds, uh, this dogma needs to be revisited. It's very important that we revisit this dogma that all severe pulpitis is going to be irreversible, will lead to necrosis of the pulp, and either has to be treated with, depending upon the extent, pulpectomy or a root canal treatment. Uh, this initial concept or this concept in the time past of severe pulpitis being irreversible was because of our limited understanding of the molecular process involved in pulpitis. So we need to understand that the cells of the pulp, which we discussed in the previous slides, along with its physiological properties, can actually, it helps us to understand that this dogma of irreversible pulpitis being totally not treatable by conservative procedure has to be revisited. And one very important reason for this is numerous studies have actually shown the clinical severity, the clinical signs and symptoms you elicit from the patient in a tooth which is subjected to a pulpal insult does not necessarily correlate with the histological picture or the histological severity. So the patient may have marked signs and symptoms, but the pulp may still have the capacity to limit the inflammation, heal itself, either repair itself or regenerate itself, so that it can have its normal function and its normal lifespan eventually. Okay, the reference is given at the bottom, and I thought this was a very, very concise tabulation of what actually happens with the different cells in the pulp, which you see here in the figure on the left. And of course, you see the odontoblasts and the dentin. So this complex here, how exactly does it respond to trauma? How exactly does it respond to any of the insult? Stay with me here because this is a very complex table, and let me see if I can take you through the components so that it's easier to understand. Right there, you have the different components: the nerves or the neurovascular network, the stem cells, which I spoke about, the fibroblasts, the immune cells, including the dendritic cells, the odontoblasts, and the dentin. In fact, the dentinal matrix also has a very critical role uh, in the defense mechanism of the pulp. On the vertical column on the extreme left, you have what exactly happens during the damage to the pulp. So what exactly is activated? What is the next step? What we call signal transduction. How do the cells communicate the damage to the adjacent cells so they can all respond as a team? What are the molecules involved in the immune response? Excuse me. What are the effects of this immune response? And if you remember that I had those two red boxes, immunity leading to inflammation and repair. So what exactly happens? And what is the type of defense mechanism? If you look at the neurovascular network, one of the important component in its role is the production of IL-6. And you have the NOS pathways. You have numerous neuropeptides. Once again, this underlines the fact that the ectomesenchyme, which forms the pulp, are from neural crest cells. So there is a significant neural response as far as the immunity and response of the pulp to trauma or any insult is there. NO plays a very serious role, nitric oxide, and all these monitor the intrapulpal pressure, the vascular permeability, recruitment of other immune cells, and in fact, growth of nerves, which is re-innovation is one of the important concepts in regenerative endodontics. When you come to stem cells, this is very important. You will hear a lot of talk about something called PAMP or PAMs and what is called TLRs and PRRs. This is nothing but PAMP refers to pattern associated molecular pathology. So these are molecules which are very involved in what is called as innate immunity. So they do not have to sort of identify a particular type of antigen domain. It's the basic structure, and it could be either the DNA of a bacteria, or it could be something like a lipopolysaccharide of the membrane associated with the bacteria. And these interact through what are called pattern recognizing receptors or pattern recognition receptors on these stem cells or reserve cells. And they coordinate their action through what are called toll-like receptors. So this entire complex of PAMs, your PRR and TLR, is what is called as innate immunity. This is sort of the first line of immunity, or what is called an immediate response to any trauma or any injury to the pulp. They work via a pathway called the MAP kinase pathway and mediate through the vascular endothelial growth factors. And these eventually uh, lead to dentin formation and immune modulation. Uh, the way this acts is the moment the cells recognize this foreign material or a bacteria or an antigen, they produce a lot of cytokines. The cytokines are the most common cytokines in pulp include what's the IL-1, then you have the IL-6, the IL-8, I think IL-12, if I remember correctly. Yeah, you have the list right here. And these in turn activate downstream signaling pathways, which include your PI3 or phosphatide, inosine 3 kinase pathway, your AKT pathways, the STAT pathways. And these are not just theoretical concepts, because if you're going to devise strategies, and probably this was discussed yesterday, to limit the inflammation, to limit the damage because of inflammation, to modulate the inflammation, to manipulate the immunity, you need to understand what are these pathways, and we have how you can tackle these pathways in the interest of the health of the pulp. Then the fibroblasts also have a similar function through PAMs, PRRs, TLRs, and they act through what are called chemokine cytoreceptors. You have the CXC motif, and these are a list of cytokine receptors, and the matrix metalloproteinases and the inos in the extracellular matrix. And these are also involved in production of pro-inflammatory cytokines and complement components. They involve what are called liposaccharide recognition compounds. And this is the MAC is what is called a membrane attack complex. It's also part of the innate immunity and the complement system. I'm sure you're aware that you have the humoral immunity by the B cells, the cell-mediated immunity by the T cells, and you have the complement system, which complements the B cells and the T cells. And they act for formation of what are called membrane attack complexes, or MAC. Then you have the dendritic or the immune cells. These are so-called antigen-presenting cells, and they include macrophages, and these can modulate the inflammatory response to maintain the health of the pulp. And this is also a very important thing to keep in mind. The odontoblasts are not only involved in dentinogenesis, they are also actively involved, along with the other cells, in producing or modulating the production of pro and anti-inflammatory cytokines, recruitment of dendritic cells and macrophages to modulate the inflammatory response, and fight out bacterial invasion or physical damage to the pulp. And this we often forget, the dentinal matrix itself. When, once again, I talk about caries because that's the most common cause for damage to the pulp in a clinical context. When there is demineralization of the dentine by the bacterial acids, it releases a lot of growth factors, including TGF-beta, your bone morphogenic proteins, your platelet-derived growth factors, vascular factors and fibroblast growth factors. And this itself triggers the recruitment of both stem cells and inflammatory cells, uh, leads to pro and anti-inflammatory processes, angiogenesis, and these can cause cell proliferation, differentiation, and new dentin formation, with sorts of balances for the demineralization, which initiated this whole process. And this is also responsible for the sclerosis of dentinal tubules in the long run. So all these processes together, the innate immunity, the acquired immunity, your nerves, the endothelial cells in the blood vessels, your fibroblasts, your odontoblasts, your stem cells in the perivascular niche. So they are all in a manner of speaking, in a dynamic equilibrium. They talk to one another, they interact with one another, so that when there is any insult to the pulp, you have an initial inflammatory process. This inflammatory process is limited, and once the inflammatory process takes control of the insult, manages to sort of suppress the bacterial infection or the trauma associated with the pulp, you get the subsequent stages of proliferation, differentiation of new odontoblasts, and then dentin being laid up. So this is the process of repair and regeneration. So repair is nothing but restoration of the tissue architecture, here the pulpal and the dentinal matrix architecture, and the function. So both architecture and function after injury. But the interesting thing is there are two variations of repair. Repair could result in either what's called regeneration or replacement. And this is very important to understand. When we say regeneration, what we mean is reconstitution of the damaged tissue by tissue very similar to the original tissue, and complete restoration for the most part of its biological function. Whereas replacement usually is a sequelae of severe inflammation, and you will get architectural replacement, but it would not exactly resemble the tissue which has been damaged, and the restoration of function is not complete. A classic example would be like replacement of a parenchymal tissue, like say liver, by means of scar tissue. So there is healing, but you do not get the liver cells back. You get only a scar tissue. So similarly in the pulp, you may not get a proper dentin. You may get something like an osteodentin, which is hard, which serves the purpose of having an architecture similar to that of what was destroyed, but it's not completely the same, and the function is not exactly what uh, of the cells or the tissue which has been lost. So it's very important to understand how we use these terms when we talk about repair. Are we aiming for regeneration, or are we happy with replacement? So what exactly we've been talking about so far is that all the components of the pulp or the dentin pulp complex, including the cells and extracellular matrix, respond to the noxious stimuli. It's just not the blood vessels, it's just not the neutrophils, just not the inflammatory cells. And the response is vascular, and that leads to inflammation, which by definition is what inflammation means. Inflammation is response of vascularized tissue to injury. And this inflammation, if handled well, does not always necessarily lead to irreversible damage of the pulp. It can lead to proliferation of new cells and differentiation so that the dentin pulp complex regenerates and is repaired. And these are mediated by both cytokines, which are necessary for molecular communication between cells, what we call signaling, and the different molecular pathways. And eventually, this may lead to repair and regeneration. Repair is good, regeneration is preferable. When I say repair is good, I mean replacement. If you have just replacement with tissue so that the vitality of the pulp, at least clinically, is there, that's okay. But ideally, we should aim for regeneration in the clinical context so that it closely resembles the tissue which was lost because of the damage. This is once again a busy slide. You have a reference at the bottom. The point of this slide actually is in response to any trauma, there is inflammation. Subsequently, the inflammation is handled very effectively. It goes on to proliferation. And once this is controlled optimally, you have remodeling in which you get the reparative dentin and healthy part. Now, the important thing in this slide is the fact that each of these have got a red box right here. This is the boundary between inflammation and proliferation and remodeling. So these are different phases in the response of the vital pulp to injury. So there may be a little bit of overlap as far as time is concerned between inflammation and proliferation and remodeling. But there are key factors which control this. For example, you have these bunch of cytokines here, IL-1, H6, macrophage chemotactic factors, and TNF-alpha, prostaglandins, and reactive oxygen species. Proper modulation of these will make sure that the pulp does not become necrotic and pushes the pulp towards proliferation. And this boundary is very nicely controlled by the macrophages and the T regulatory cells. So if the inflammation is not acute and rapidly progressing so that the pulp does not have any time to repair itself, then the macrophages and the T regulatory cells take over from the acute inflammatory component. Then they recruit cells such as the stem cells, the progenitor cells. Then you have a bunch of other cytokines coming into place, such as the platelet-derived growth factor, the IL-10s, the TGF-betas, the resolvins, the matrix metalloproteinases, and vascular endothelial growth factors. These will lead to differentiation of these cells, the progenitor cells, the so-called mesenchymal stem cells, and the other cells, reserve cells, so they can differentiate into odontoblasts and completely replace the dentinal matrix or the pulpal tissue, which has been damaged by, say, the bacteria because of caries. The point of this slide is to tell you that this is a very dynamic process over a period of time, where you have inflammation, which limits the damage. Once the damage is limited, you have cells which can proliferate, and these cells which proliferate can completely replace the tissue which has been damaged because of the inflammation. And you have all these factors. So when we talk about regenerative endodontics, we talk about growth factors which can help the pulp to regenerate. So these are the factors we are talking about, which are critical in each step of pulpal recovery from damage. All this is fine. You have a group of cells, you have extracellular matrix, you have cytokines, you have the process of inflammation, proliferation, and differentiation. But where exactly do they fall as far as clinical practice is concerned? Let's take a quick look at that. These are processes which you are all probably have very less practical knowledge of this, other than the fact that this is what you aim for. You can aim for apexification, where you form something like a dentin, and you get a closure of the apical foramen so that the function of the tooth is sort of restored. You have apexogenesis, where actual root formation can be allowed to continue by limiting the insult to the pulp. And then you have regenerative endodontic procedures. The fundamental aim in all these is to have what we call as a minimally invasive vital pulp treatment. So with very little interference, you handle the pulp so that you do not lose its vitality. I mean, that I think is the ultimate goal in clinical practice. So this is the goal which we all strive for to maintain the health of the pulp and to manage the patients in a clinical context. And this is the fundamental basis of what is now widely popular and what is called as the regenerative endodontic procedure. This history I'm sure you're all aware of this more than I am actually. But the point of this history is to look at the one which is slightly of a different color here. Now, it's very interesting if you look at how exactly this clinical concept of regenerative endodontic procedure evolved. So that gives us an idea of how we learned about what the pulp, or what we now call the dentin pulp or pulp dentin complex, actually behaves. So some of the earliest understanding of what happens to the pulp is how the pulp responded to dental restorative materials. This led to an interest in dental tissue regeneration. This led to animal experiments for dentin and cementum regeneration. And once we had a sort of a broad idea of what exactly was happening in the pulp, there were investigators who were working on trying to use blood clot and how you can help the pulp to heal using the blood clot. Then the concept of using barrier members in healing of the pulp came into play. And once we started using pulp and once plasma-derived products became popular, the question came out as why can't we use plasma obtained fiber or plasma products along with scaffold to initiate pulp healing. Then you had the evolution of revascularization and root development, which eventually led to formation of clinical protocols for revascularization. And this is often talked about, revascularization in managing the pulp in the clinical context. But I see a lot of other terms which are also used in the place of revascularization. Some people call it revitalization, and some people put all these into the broad concept of regeneration. So you have what we call as revascularization, what is called revitalization, and regeneration used interchangeably in the literature. But all of them sort of have the same meaning, that you're trying to save the pulp, you're trying to restore the original architecture and function of the pulp subsequent to any damage it might have undergone. So what exactly do these three terms mean? All these three, regeneration, or be it revascularization, or be it revitalization, means biological procedures to stimulate the restoration of tooth tissues, including the pulp dentin complex and root formation. And that's very important. So the ultimate aim is to resolve the pulpal and the apical inflammation, to get radiographic evidence of root development and the apical narrowing, and clinically restore vitality responses to the tooth. So this is the ultimate aim of regenerative endodontics from the clinical context. So you resolve the inflammation, you make sure that the root development in an immature tooth in which the pulp has been damaged continues to happen with good apical narrowing, and the tooth becomes vital again. I'm not going to go into this in detail because you are all the experts in this, but the fundamental steps are important from the biological point of view. Canal disinfection. And that's the 101 of treating any infection. If you have bacteria, you need to remove the bacteria before you can even think about healing, controlling the inflammation and regeneration. And then, of course, you use cells and biological compounds which facilitate the regeneration. And then, of course, close the damage or repair the damage which has been caused and then follow up. These are the fundamental steps of any clinical procedure. So let me stick to what I know something about, cells and the biological compounds needed for regeneration. There are three approaches you could do. One, what is called as the revitalization or revascularization. You could do what's called cell transplantation, and then you have what's called cell homing. Okay, you have the labels right at the bottom right there, revitalization, cell transplantation, and cell homing. In its most early stages, in its most primitive stages, is basically inducing bleeding within the tooth. The blood has got a lot of inflammatory cells, growth factors, and it's a fantastic medium for healing to take place. And we assume that once you have blood, the normal blood components will enable the tooth process and help us to achieve the goal of regenerative endodontics, which we saw a few slides back. In the case of cell transplantation, you take a few cells, And obviously, you need a media in which you need to put the cells, what we call as a scaffold, and then put it inside. In the case of cell homing, you just put the scaffold and with some growth factors which will attract all the cells we spoke about in the earlier slides, the fibroblasts, the reserve cells, the stem cells in the perivascular niche to come. All of these processes, be it revitalization, transplantation of stem cells from outside into the pulp, or using the pulp, which is the cells which are already there in the pulp, a few of them, to home them, sort of to attract them with scaffolds and growth factors, is called cell homing. All these uh, need growth factors. And these growth factors are nothing but all the factors which we saw a few slides back, your interleukins, your platelet-derived growth factor, your vascular endothelial growth factor, your bone morphogenic factors. Those factors which are responsible in normal healing, you add them onto cells. And that's how the process of any of these three, the revitalization, the cell transplantation, or the cell homing works. And for this regeneration to happen, either be it revitalization, transplantation, or homing, you need three things, and three things need to happen. This is the most simplified form of understanding it. If at all you take home a message, this should be the slide. For any endodontic procedures, you need the threes. You need stem cells or cells which can migrate and differentiate. You need growth factors so that they can migrate and differentiate and proliferate. And to hold all these in place in the correct position, you need what are called scaffolds. And what do these do? What do the stem cells do? What do the growth factors do? And what do the scaffold do? They are necessary for angiogenesis so that you get new blood vessels. They're necessary for reinnervation so that the tissue, which is sort of repairing itself, has got the capacity to respond to stimuli later on and the tooth becomes vital. And most importantly, you need the anatomic replacement so that the cells can differentiate and actually form the root. So this is the fundamental core of regenerative endodontics. The necessity for stem cells, scaffold, and growth factors. And these three interact with one another so that you get angiogenesis, reinnervation, and appropriate root formation so that the anatomy of the tooth is sort of restored. Very, very briefly, I will talk about stem cells because I think you need to understand that this term is used very loosely. What exactly are these cells? Where do they come from? Are there different types of stem cells? Obviously, yes. Now, this is very important that you understand that stem cell is like any other cell. But what it does is it both divides and differentiates. And this is sort of, at the expense of using a very cliched term, it's an oxymoron. Because normally, cells which can multiply or cells which can divide are not very good at differentiation. And cells which are very good at differentiation do not multiply very well or divide very well. So this is a fundamental process that proliferation is sort of inversely proportional to differentiation, sort of loosely speaking. But what the stem cells do is what is called as an asymmetrical cell division. When a stem cell divides into two, one of them differentiates and one of them goes back into the stem cell pool, what is called the self-renewal process. And this is very unique for stem cells. So basically, it can differentiate and it can go back to the pool of stem cells in that particular organ. And broadly, they can be embryonic, adult, or they can be obtained by what is called as lab manipulation, such as the IPS techniques. So depending upon where you get the stem cells from, it can be embryonic, adult, or lab manipulation. And this is a slide you probably have seen in multiple different formats. If you get it from the embryonic stage, these are what are called totipotent because they can form almost any tissue. And then when you get it from the blastocyst, they're called pluripotent stem cells. We're not worried about this in our current topic, which we are discussing. What we are really concerned about is so-called the adult stem cells. And that's exactly what we're talking about when we talk about regenerative endodontics. These are present in different organs, brain, bone marrow, or skin. And here in the dentin pulp complex, these are what are called as multipotent. They have a limited capacity to differentiate into cells. And we talk about the dentin pulp complex, they can probably differentiate into fibroblasts, odontoblasts, which lay down dentin, and maybe a little bit of endothelial cells. That's it. That's a limited capacity to differentiate. And this is what we're talking about, the adult cells, when we talk about the so-called mesenchymal stem cells in the perivascular niche in the adult cell. And once again, I'm sure this has been spoken about in the previous lectures. You can get stem cells from the dental follicle of an erupting tooth, from the apical papilla region. You can get it from both permanent teeth and deciduous teeth. You can get it from the pulp, and you can get it from the periodontal ligament. And at the expense of repeating myself, these cells are very, very versatile because they are ectomesenchyme derived from neural crest cells, which have a wider capacity of differentiation than stem cells from other tissues in the body. And I think if you wanted to be a little bit more extensive, and this has been taken from one of the textbooks, conservative textbooks, you have all the different sources. They could be from a deciduous tooth, a permanent tooth, they can come from the periapical region. They can be from salivary glands, and you can get stem cells from the bone marrow. And you have numerous areas in the maxillofacial region from which you can obtain the stem cells. And how do you use the stem cells? Homing. So the stem cells which are already there in the pulp, you can activate them using growth factors and scaffolds and sort of stimulate them to come into the odontoblastic regions where they differentiate into odontoblasts and lay down dentin. So that's called the homing process. Or you could take pulp from some other patient or the same patient from some other tooth. Let's say you need to do a regenerative endodontics in the first molar and the patient needs an extraction of the third molar. You could take the third molar out, take the pulp cells, expand the stem cells, and then put it into the first molar for regenerative purposes. But trying to transplant these cells is a little bit tricky because there are a lot of ethical issues involved because you need to take the stem cells out, expand them in the laboratory. And when you do that, you're going to introduce a lot of chemicals in the laboratory setting. So there is always the risk of pathogen transfer, the risk of rejection of cells because you're slightly modifying it in a laboratory setting, ethical concerns if you're going to take it from some other person, and the cost factor tends to be more expensive. So by and large, we don't use the process of transplantation for regenerative endodontics. Essentially, it's revascularization or using what is called the resident stem cells in the process of homing using growth factors and scaffolds. So what are these growth factors? Like I said, these are the factors like interleukins, bone morphogenic proteins. We saw in the slide which discussed inflammation, proliferation, and differentiation. This is a very good article which was published. There are more newer articles, but this sort of actually explains all the key growth factors and morphogens present in the dentin, actually, known to play important role in regeneration and repair. I'm not going to go into the slide extensively, but just to give you an idea, some of the growth factors include transforming growth factor beta and its different isoforms, bone morphogenic proteins, insulin growth factor, hepatocyte growth factor. And each of them has a purpose. Some of them cause migration, some of them cause proliferation and survival, and each has a specific function in the triumvirate of having either contribute towards inflammation, proliferation, or differentiation, which helps in healing of the dental pulp complex. You have platelet-derived growth factor, epidermal growth factor, placental growth factor, and so many other factors. Now, these factors can be used in the clinical context to help the pulp regenerate itself so that clinical management of a tooth which has undergone an insult is effective. Once again, this is just a slide to show you that the dental stem cells have got the capacity to undergo neurogenesis, angiogenesis, odontogenic differentiation. And because they're of neural crest, they've got fantastic capacity to migrate and proliferate so that you could place them in one part of the tooth. They will migrate, proliferate, and depending upon how you place the scaffold, you can get a healing in that particular region. So the dental stem cells are very, very versatile, and when used appropriately, will help in restoring pulp anatomy back to normal. Okay, this is a busy slide, but this sort of puts in together all the factors. Just stay with me here. What it shows is the growth factors here. This is this blue structure which you see is the cell membrane. This is the cytoplasm. So we have different growth factors such as Wnt, bone morphogenic protein, THF-beta, sonic hedgehog. All these, they interact with receptors on the cells. And when I say cells, it could be fibroblasts, it could be odontoblasts, it could be stem cells, it could be endothelial cells. And once they interact with these receptors, they activate numerous pathways. The important pathways are marked in green, your PI3K, phosphatidylate inosine 3K pathways, your AKT pathways, your ERK pathways, say the serine, threonine, or tyrosine kinase pathways, your MAP kinase pathways, and the JNS and STAT pathways. And each of them has got a particular role. These are color coded. All the blue arrows lead to what are called cell migration. Then you have some of the pathways contributing towards cell proliferation, some towards angiogenesis, some towards neurogenesis, and some towards odontogenic differentiation so that the cells differentiate into odontoblasts, lay down dentin, which has been demineralized, and repair the damage to the dentin at the point of injury. And there are different ways in which these can be used. And so we can harness this knowledge, which we didn't have a few years back. So now we know exactly what are the growth pathways, what receptors they act through, or what are the downstream and upstream signaling pathways, and what exactly they help in, whether it's be it migration, proliferation, angiogenesis, neurogenesis, or odontogenesis. So we know the factors which are responsible for each of these and at what stage in the inflammatory and repair process these are active, and when and how you need to sort of introduce them into the damaged pulp so that you can have an effective clinical management of the injured dentin pulp complex. I'm going to skip this in the interest of time because I think I'm running out of time. We can always discuss about the scaffolds a little bit later. That's just more from the treatment aspect of regenerative endodontics. I'm just going to quickly skip this here. And come to the conclusion. The pulp and dentin is a complex tissue. And like we have discussed, the cells and the extracellular matrix interact with one another in a very, very dynamic fashion. And this is the fundamental basis of the inflammatory response. And inflammatory response doesn't always mean that the pulp is going to be severely damaged and severe inflammation. Now that we know the unique anatomy and the physiology of pulp and how exactly the homeostasis in pulp is maintained, we can harness this to attempt repair and regeneration of pulp. And this involves three important substances: the stem cells, which are there in the perivascular niche. These are neural crest in origin, and they're very unique because they are ectomesenchymal as far as the teeth are concerned. Growth factors, we saw a bunch of different growth factors, which are very critical in all the three phases in response to injury, be it inflammation, proliferation, or differentiation. And these two can be delivered by use of special scaffolds, which are of different types. And the purpose of introducing the stem cells, the growth factors, and the scaffolds, either the process of revascularization or the homing technique or the transplantation technique, is to make sure that there is new blood vessels, new nerves, and the tooth is complete so that the anatomy of and the function of the tooth is completely restored, and we achieve regeneration. So our knowledge of this dentin pulp complex has actually expanded to such an extent that we know the minutiae involved in pulp homeostasis and how we can leverage this so that we truly employ what is called minimally invasive vital pulp techniques to save the tooth in the patient and provide an optimal clinical response. Thank you for giving me your undivided attention, and thank you to the organizers for having given me an opportunity to share some of these ideas with you all. Hopefully, they are useful to all of you. Thank you very, very much.
Um, Thank you very much, Dr. Ranganathan, for that insight right from the very beautifully done from right from the formation of pulp to the different the cells, the biomolecules, and towards inflammation, pathology, and their repair, and a little about regeneration. We have a couple of questions. One is from Dr. Kritika Datta. Is how much do you think is a reality towards the regeneration of pulp? We sort of used to say that it is regeneration, but then we have started telling it as to more of a revascularization than regeneration. So how much, as you said, like pulp like tissue, so how much is a reality towards forming a almost pulp like tissue?
That's why I studiously kept away from the clinical concept. I think currently, uh, 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 I mean, you have the learned senior members in the audience, they can correct me. There are certain limitations, like you need to have zero point 0.5 to, I think there's a European standard, zero point 0.1 to zero point 0.5 millimeters apical foramen being patent. It's more obviously good in, younger patients. When I spoke about all these reserve cells and stem cells, one important factor to consider is with age, the quantum of the cells become less within the pulp. So exactly how do you stimulate these? So there are limitations. Uh, Regeneration is still possible in an immature tooth with the correct apical foramen measurements in young patients. That's the first step, obviously, like any regenerative medicine. As the patient becomes older, I think it's not very practical. Revascularization is definitely an option. But I guess the important thing is we are talking and we are finding out methods. So regeneration will work in certain specific contexts at this point in time. Hopefully, as our knowledge sort of expands, we may be able to expand it to those areas in which we're not able to use it now, currently. So it is practical, but in a limited context. Yeah.
So in that context, what do you think, like, if the pulp is partially necrosed or partially diseased, and we do a vital pulp therapy, so how much do you think that regeneration of the pulp dentin complex is possible with the existing vital pulp?
Oh, yeah. Yes, it is definitely possible. The critical factor you need to consider, think about it this way. When the process of apexification started in endodontics, uh, the biggest problem with apexification was the fact that you had to repeatedly instrument the canal so that the canal became very weak. And because you were placing the medications repeatedly, there's a chance of reinfection. And we sort of overcame that with MTA and biodentin. So the number of repeated processes totally became very less. So similarly, I think in a partially necrotic pulp, in a good host response situation, definitely very successful. So there's no doubt about that. And I think that's the requisite for regenerative endodontics. And as our techniques get better, the requisite may become less stringent and we may be able to use it in a wider clinical context. That's exactly what's possible. And that's true for any part of medicine, because we are actually just sort of, I probably wouldn't be exaggerating to say we're just pioneers in this field at this point in time. And as the knowledge expands and our technique becomes more refined, I'm sure it's going to be more widely useful. Probably not in all contexts, but at least the context in which it's going to be applicable are going to be significant. Hi, Dr. Murli.
Yeah, Dr. Murli has a question, so I think he can ask it directly.
Yeah.
Murli, over to you. You can unmute yourself, please. Murli, you need to unmute.
Unmuted. Okay.
Ah,
Are you able to hear?
yeah. Yes.
You need to unmute.
Okay.
You're not heard.
Not hearing?
I can hear him. It's okay.
Okay.
Yeah.
Okay. No, just of course this is almost it's going on for 15, 20 years, almost 2 decades. How long we may be able to wait for an foolproof material to start actual revascularization? Because it comes and goes, and of course not all materials are promising, but foolproof. What are the status of the research? How far are we, or how short are we in terms of time?
Yeah, I think uh, that's a difficult question, and like basically gazing into a crystal ball, actually. Um, I think most of the research is now focused on scaffolds.
Okay.
There's a tremendous sort of interest in scaffolds. And that's why I was very careful to deconstruct those three things, the stem cells, the growth factors, and
Yes.
scaffolds. We know a lot about stem cells. We know a lot of growth about scaffolds. Scaffolds have really come a very long way, actually. The tricky thing is the growth factors and the timing of the growth factors, how you use it with scaffold. So I think we have reached a long way with scaffolds. We have crossed the bridge almost three-fourths with scaffolds, and we have fantastic material available now. Our knowledge of stem cells is fantastic. We know how to manipulate them. We know how to home them. But the tricky part is what growth factor you use, when you use, and how you time it. And I guess your guess is as good as mine when we are going to do that.
What are the shortest time you have come across a reasonable amount of revascularization? That is the third criteria for us to achieve. Your pulp sensibility test is positive. What are the
Uh,
shortest
that,
time?
that, that that's the biggest advantage in being a pathologist. I let the clinicians answer that question. I have no experience with that. I will allow
Okay.
the clinicians to answer that.
Murli, I think it is almost past 1:30 a.m. in Toronto, from where Dr. Ranganathan is doing his presentation. So
I
I
didn't
think
know. Sorry. Okay, then.
No problem.
I thought he was from
No
Hey,
problem.
Najma. Okay, Ranga, no problem. Yeah.
No problem. No problem at all.
Thank you,
Yes, few
no
more
problem.
questions. Yeah, sure, no problem.
no, I think we stop here, we end here, and we let you go to sleep in the morning. So thank you very much, Dr. Ranganathan, for taking up, and it was a crystal clear presentation as usual from you. So token of appreciation, when you come back to Chennai, we give it to you. Thank you so much.
Thank you for the opportunity. Thank you very much.